Fine. So I think we can start. So welcome to the ERI EDTA's CKJ Journal Club. Each e-seminar takes place on the last Thursday of the month at 17:30 Central European Time, which is 16:30 UK time. Each of these e-seminars picks out a topic from a recent CKJ original research or key review article, and the author or authors will introduce their work, and there'll be at least one expert panelist. It's moderated by myself, Will Herrington, an Oxford-based nephrologist and epidemiologist, or by the CKJ editor-in-chief, Professor Alberto Ortiz. And the discussion lasts up to an hour. It's fairly informal, it's live, and hopefully you'll send us lively questions, which you can type into the Zoom Q&A boxes, and we'll monitor them and try and answer as many as we can during the time. And it will be recorded and made available on various platforms afterwards, so keep an eye on social media. This week is actually our second e-seminar. Unfortunately, the timing naturally clashes with Thanksgiving in the US, so our thoughts are with the on-call renal teams in the US during this holiday period and their families. The COVID-19 vaccine trial results and other developments recently give us renewed hope. But today's topic is on intravenous iron and cardiovascular disease. 2 weeks ago, the AFFIRM-2 trial was published in the Lancet. Some of you may be aware, but it was a trial in acute heart failure of intravenous iron with ferricarboxymaltose in 1,100 patients admitted with acute heart failure. And patients had some evidence of early iron deficiency. And excitingly, it demonstrated reduced risk of rehospitalization for heart failure compared to the placebo comparator. So IV iron is again in the spotlight. It's a real promise as a cardioprotective therapy. And so it's very appropriate that today we are bringing up the topic again of intravenous iron and cardiovascular disease, but specifically thinking about it within our renal populations. The CKJ review has been e-published today, and it summarizes the deliberations of the ERA EDTA's Europe Renal and Cardiovascular Medicines Working Group, known by the acronym EURECA-M. And we have two of the authors here to present some of the discussions. We have Professor Lucia Del Vecchio, who is a nephrologist from Como in Italy, who's first author of the paper, and she'll be providing some interesting mechanistic evidence that supports the use of IV iron. Welcome, Lucia.
Hello, good evening, everybody. Thanks for inviting me for presenting our paper.
And we've got Professor Patrick Mark, who is a nephrologist at the University of Glasgow Institute of Cardiovascular and Medical Sciences, and he was a member of the Pivotal Adjudication Committee. And rather impressively, Paddy, you've got 2,800 followers on Twitter, which means you're among the renal Twitterati.
Yeah, and thanks for having me all. And to spice it up, all the lights have just blown in my study, so I'm sitting in the dark. So I might move around the house during the presentation to try and get lit better. So
I hope your computer remains powered.
Yeah.
Okay, well, welcome, Paddy. Paddy's going to focus a bit more on the TRAM evidence and was a co-author with Lucia. And then our expert panelist is Chris Winearls, who's an Oxford-based nephrologist as well. He's been a long-term mentor to myself. I think he called me my wingman. He's my wingman. No, I was his wingman. No, I can't remember which. We were somehow supporting each other's wings. But he has recounted to me many of the stories of the renal anemia and how it's passed over time. It's counted amongst his interests. He was on the steering committee of the pivotal trial, and I'm really incredibly grateful that he's interrupted his retirement to join us today.
Delighted to interrupt my retirement.
So the first talk is from Lucia. Maybe before you present your findings, you could just explain how you got interested in intravenous iron specifically.
Well, I've been working for, unfortunately I'm old, for 20 years in Lecco, and there we have participated to several clinical trials around the development on ESAs and erythropoietin, and also some studies with intravenous iron, such as the FINE study. And so year by year, I focused on the field of anemia and CKD.
Great. Well, I read the paper. It was so interesting that we thought we could dedicate an e-seminar, maybe even two, to it. So I think without further ado, please, could you introduce us some of your thoughts about the mechanisms and the deliberations of your working group?
Yeah, I start. This paper is the result. I hope it's a good result coming from the combined work of all the members of the steering committee of the EURECAM working group. And first of all, I want to thank all of them, all the co-authors, for their effort. And also, I think it's a good point of reflection, because when you work together, you always learn something from the other, from different expertise and scientific interests. And let's start from the physiology of iron metabolism. As you know, iron is number 26 on the chemical table of elements.
Lucia, I don't think we can see your slides yet.
Wait, okay.
Try again.
I started.
They're in a box. They're in a box.
No, I did it. Okay, I do it again. Okay.
Try again. There. Yes, we can now see a computer screen. Yeah.
Okay, good. I go back.
I think, yeah, perfect.
Okay, there it is. Okay,
yeah,
sorry for the mistake.
Done. That's good.
The first slide presenting all the co-authors of our paper, the EURECAM working group with the steering woman Francesca Mallamacci as our leader. And let's go back to the physiology of iron metabolism. Iron is the 26th element of the table of chemical element. Okay. It is the fourth most common element is the Earth's crust, and it is also the second more frequent metal following aluminum. It is essential for cell growth and survival, going from animal cells, but also for bacterial cells, for DNA synthesis and repair, mitochondrial function, and for the regulation of inflammation. It is also the most abundant transition redox active metal, since, as we know, all the metals are very active in releasing and upsetting electrons. It is also an essential constituent of hemoglobin, and that's, of course, why it is a topic of today. Iron, as we said, it's very, very reactive in releasing and giving electrons. This causes a famous phantom reaction, which causes the transition from ferrous iron to ferric iron, and releasing a number of hydrogen peroxide and causing lipid peroxidation. The contrary reaction is the Haber-Weiss reaction, causing the transformation of iron ferric to ferrous iron, and due to the action of superoxide. Both reactions causes the formation of free radicals that can be toxic for cells, and this is the reason why excessive free iron could be toxic if not adequately controlled. In addition to this, free iron is important for the replication of several bacteria, and especially for bacteria for endocellular proliferation. This is another reason to tightly relate iron. Systemic iron balance is tightly regulated. For this reason, a number of specialized transport systems and membrane carriers have been developed to maintain iron in a soluble state, which is suitable for the circulation into the blood and to transfer iron across cell membranes. Overall, our body contains around 3-4 grams of iron. The majority of this is not in a free state. 1 gram of iron is stored as ferritin in reticular endothelial system, in spleen and the liver. 2 grams is enclosed in hemoglobin in circulating red blood cells, and another quarter is stored in myoglobin and in enzymes around the body. Free iron transported iron represents just 3 milligrams of the whole body store, and this pool is as an entrance, that is the absorption from the gut, around 1-2 milligrams every day, which is regulated to replace losses in physiological condition, 1-2 milligrams. These losses can be increased in several conditions, going from bleeding or pregnancies. And another important consideration to do to this system, that losses cannot be increased. So in condition of excessive iron balance, the system is not able to reduce iron stores. Serum hepcidin was first described in 2000 and is now considered as a master regulator of iron metabolism. As you will well know, this is a 25 amino acid peptide which is synthesized by the liver. It was originally identified as an antimicrobic substance. However, thanks to studies coming from hemochromatosis, it is now recognized as a master regulator of iron. The main function is to sequestrate iron and reducing iron availability coming from absorption of the gut and recycling coming from splenic and hepatic macrophages. This is the reason why we can see that hepcidin has been put in the center of this graph. On top, we see his regulators. And there is an intracellular iron sensor. There is erythroferron, which is a hormone described first in 2014, which is released following increased erythropoiesis, and inflammatory factors such as interleukin-6, bone morphogenic protein 6, and TGF-beta. And then there is ferroportin. Ferroportin is the factor of the system, and it can be considered the top of hepcidin. The higher is hepcidin, the lower is the iron transported by ferritin. In the active state, ferroportin is a transmembrane protein, and it can allow the transportation of iron from inside the cell to the outside. However, in the presence of serum hepcidin, ferroportin is internalized inside the cell and goes as directed towards lysosomal degradation. And in this state, ferritin accumulates inside the cells and cannot go out. In recent years, new evidence have emerged that iron metabolism is among the several functions of the body that are orchestrated by the hypoxia-inducible factor system. As you can see, if2 alpha can act on several points. It can indirectly decrease serum hepcidin. It can increase iron availability by enhancing its absorption from the gut, releasing it from deposits. It can also influence serum transferring. There are several experimental evidences which have included atherosclerosis development and iron availability. This is not surprising given the interplay of oxygen with iron, and for this reason, the possibility that iron could regulate arterial homeostasis. The animal models have shown that when exposed to iron restriction, that could be due to reduced iron with the diet or iron chelation, they developed less atherosclerosis and develop atheroma plaques at lower extent. On the contrary, animals which are given iron supplement or intravenous iron can possibly develop worse atherosclerosis. However, these data are not univocal in the literature. In addition to this, iron accumulation has been seen in several cells involved in the development of atherosclerosis. One is smooth muscle cells, which can go to increase or reduce proliferation. Iron can accumulate in monocytes, and in these monocytes, this goes together with LDL accumulation, increased LDL oxidation, and these monocytes are activated towards the M1 morphology, which is the pro-inflammatory state. And finally, iron accumulation in endothelial cells can increase the expression of adhesion molecules such as vimectin. Atherosclerosis and the link between atherosclerosis and iron availabilities and also been demonstrated in humans. Starting going back to 30 years ago, with the theory of Silverberg, there had been hypothesized that lower iron was protective in respect to the development of atherosclerotic lesions. Well, in addition to this, it has been shown that iron can accumulate in atheroma plaques in humans and can correlate with cholesterol levels. The role of the accumulation of iron in symptomatic plaques has been largely debated because it is still unclear if it is causative or not. Indeed, symptomatic plaques are often hemorrhagic, so the detection of increased iron could be just simply as a consequence of bleeding rather than a causative role of iron. Iron supplement could cause the increase, as said before, of adhesion molecules. And finally, excessive iron dose given intravenous has been associated with an increase in intima media thickness. It has been largely debated the role of functional iron deficiency and positive iron balance, and is linked with increased atherosclerosis. As I think all of you are aware, functional iron deficiency is defined as reduced iron availability despite adequate iron stores. It is defined as a coexistence of low transferrin saturation level with high ferritin levels. However, despite this definition, there is still a lack of an unequivocal gold standard. What is quite clear, even if not completely demonstrated as well, patients with functional iron deficiency have increased risk of iron toxicity following intravenous iron administration. I'm saying that is not completely clear because theoretically this is true. However, nobody has clearly demonstrated which is the limit of excessive iron administration to cause iron toxicity. In particular, it is also unclear which is the difference in everyday clinical practice between positive iron balance, which is a predominant reticular endothelial deposition, which does not cause tissue damage, against proper iron toxicity. In this case, there is a predominant parenchymal deposition involving the hepatocyte and the later stage Kupffer cells and causing tissue damage. It is also unclear when damage occurs because it is not the same for this patient and it is not the same at the same dose of iron or at the same ferritin level. It seems that iron would expect to spill over into hepatocyte if labile plasma iron is present. What is it, labile plasma iron? Its definition has also been debated longly in the literature in the last year. It is defined as a component of non-transferrin bound iron. However, it is determination different according to the experimental models used. It is considered a kind of iron with a high redox activity and which is weakly chelatable. And labile plasma iron, it's important because it may pose the risk of oxidative tissue damage caused either by cumulative infiltration into cells, which is not regulated, or through the oxidation of plasma product oxidation. The role of labile iron, as you can expect, has been largely studied in conditions of saturation serum transferrin. It is quite obvious that if we administer iron, or we cannot control iron, and serum transferrin is saturated, there is no opportunity to further block free iron, and this has become toxic. But what about CKD patient? What we fear more is a state of functional iron deficiency. In this case, we have a low transferrin saturation level, and the role of labile plasma iron is less clear in this setting. Recently, this year, one of our co-authors of the paper, Dr. Malisco, co-authored this interesting study. This is a combined effort of two centers, dialysis centers, one in Israel and the second one in Poland. And the authors enrolled around 100 hemodialysis patients treated with intravenous irons. And they dosed plasma labile iron before the dialysis session and after 48 hours. They found that labile plasma iron became positive in 18 patients, that is nearly 20% of the patient population. Interestingly, the possibility of having positive plasma iron was higher in patients having ferritin level exceeding 500, and those who were treated with monthly iron doses higher than 250 milligrams. And well, so ferritin, high ferritin may possibly expose patients to risk. However, according to this, several studies, regional studies, found clear association with very high ferritin levels and increased mortality. This is an example coming from the DOP study for European patient. You can see that there is a cutoff level of ferritin of 400 and a progressive increase in the risk of mortality with increasing values. The relationship remained true even after adjustment for several comorbidities, general comorbidities plus anemia factors, plus nutrition, inflammation or hospitalization, plus inflammatory protein, or plus adding transfusion. However, if you go on the other side of the curve, you can see that also patients with insufficient, let's say, level of ferritin, or possibly with absolute iron deficiency, have a progressive increase in their mortality risk. What about patients not on dialysis? This topic has been studied less. However, there are some reports showing similar data as those of hemodialysis. This is an interesting study which has been published last year on Kidney International, and it is an observational study reporting the result of an historical cohort of more than 100,000 patients studied between 2006 and 2015 from the Veteran Affairs Corporate Data Warehouse. The patient population was divided in 4 iron groups on the basis of a quartile of transferrin saturation and serum ferritin. The referencing group was patient having a transferrin saturation between 16 and 28% and serum ferritin between 55 and 205. Then there was a low iron group with serum transferrin saturation below 16 and ferritin below 55, and high iron group with transferrin saturation with higher than 28 and lower than 100, and ferritin between 2000 and till 5000. And finally, a group with functional iron deficiency with low TSAT level and high ferritin level between 100 and nearly 3000. The mean follow-up of this historical cohort was 4 years. And as we can expect, patients with functional iron deficiency had the worst survivors compared to the reference group, with hazard ratio 1.21 for a risk of all-cause mortality. However, interestingly, similar curves were observed for patients with the high iron group with an hazard ratio of 1.10, but also for the group with low iron with an hazard ratio of 1.09. In addition to this, the authors find a strong association with increased mortality for the patient in the lowest quintile of transient saturation with levels below 11%. In comparison to the median quintile of this transient saturation with an odd ratio of 1.6 of increased mortality. Another interesting information coming from this study, the mortality was similar between diabetic and non-diabetic patients. This is important because increased iron has been associated from several studies with insulin resistance. And so, which is the culprit of this relationship between iron parameters and increased mortality? Are high ferritin levels possibly causative by themselves? Likely not. Is inflammation and patient comorbidities perhaps more important? Or finally, is toxic excessive iron, intravenous iron given to patients with functional iron deficiency? And well, let's see which is evidence coming from clinical trials that are available till now. And let's start from patient not on dialysis. Well, in patient not on dialysis, unfortunately, the evidence is still, let's say, quite small or not enough. The first trial I want to present is the REVOKE trial. This was a randomized trial of intravenous and oral iron in patients with non-dialysis CKD. The authors enrolled 136 subjects with iron deficiency anemia, and they were randomized to either oral iron sulfate given 325 milligrams 3 times daily for 8 weeks, or to receive intravenous iron sucrose 200 milligrams every 2 weeks with a total dose of 1 gram. The primary outcome of the study was the difference in slope of mesurated GFR change over 2 years, starting from the hypothesis that intravenous iron could cause increased oxidative stress and then be nephrotoxic. These are the baseline characteristics of the study, the patient enrolled in the study. Of course, I don't want to enter in details. I just want to show you that the etiology of chronic kidney disease was diabetes on around 400 patients, 400 patients. This is quite representative of the US population, but I want to enter more in detail on their comorbidity illnesses. As you can see, around 70% of the patient had diabetes, with this imbalance between patient randomized to oral iron in comparison to those randomized into intravenous iron. The imbalance was observed also for the percentage of cardiovascular disease and hospitalization for heart failure. Despite the imbalance, anyway, the overall proportion of patients having comorbidities, and in particular cardiac comorbidities, was quite impressive. You can see that 1/3 of the patients had been hospitalized before for heart failure, and 41% of the patients had been hospitalized for infection disease before entering the trial. The trial was terminated early on the recommendation of an independent data and safety monitoring board for 2 reasons. First reason, at this interim analysis, the possibility to find differences in the change of mesurated GFR was quite small, and also because they noted a higher rate of seroadverse events in the group of patients receiving intravenous iron. Different from many clinical trials, the study protocol looked at the incidence of seroadverse events, not as single events, but as cumulative events independently of the single patient. You can see that they found that increased risk of infective event, 36 events, 100 patients per year in those receiving iron, in compared to 25 for oral iron. and an increased incidence rate ratio for cardiovascular events, 54.44 in comparison to 34.4, chronic heart failure, nearly double, angina, the same, and myocardial infarction were the same. The authors also find a little higher number of deaths in patients receiving intravenous iron. However, in my opinion, the difference is not significant, 6 in comparison to 4 patients in those receiving oral iron. In the same period, the FINE CKD study was published. This is a larger study. It was performed mainly in Europe and in Australia. It is a 26 open label multicenter study, which enrolled 600 patients with non-dialysis CKD, anemia, and iron deficiency. We were not treated with erythropoietin stimulating agents. The patients were randomized in 2 groups with a ratio 1:1:2, if high dose intravenous ferric carboxymaltose with a ferritin target between 400 and 600, a low dose intravenous ferric carboxymaltose with a ferritin target 100 to 200, and finally, oral iron group. The primary endpoint of the study was the initiation of other anemia management, that was erythropoiesis stimulating agent, other iron therapy, or blood transfusion. The trigger for change the anemia therapy was hemoglobin below 10 during week 852. One limitation of these studies in respect to the registration of safety endpoint is that this registration stopped in the moment that the patient changes treatment. These are the baseline data of the FINE CKD study. Also from in this study, I want to enter into detail, but I just want to make you a comparison with the REVOKE trial. Let's see for cardiac heart disorder. You can see that more or less 40% of the patient had previously had cardiac disorders, and the percentage in the REVOKE trial was higher, 53.7%. Let's see infection, around 20%, less than 20% the FINE CKD trial, 41, the double in the REVOKE trial. History of diabetes, 74.3% the REVOKE trials against around 57-60% in the FINE CKD trial. And now have a look at safety data. Following the publication of the trials, 3 years after, the same author performed a secondary analysis of the studies with the idea of make their data comparable with those of the REVOKE trial. And so they gave data also for a number of events for 100 patients here during the safety period. And so let's see, first of all, in the FINE study, there was no significant difference between oral iron, low ferritin, and high ferritin groups for all the events. Let's compare them now with the REVOKE trial. You can see acute myocardial infarction, 1.4, 1.6 in the FINE study, 8.9, 8.6 in the REVOKE trial. What is even more surprising, in the REVOKE trial, the author found an increased occurrence of cardiac failure in patients receiving iron therapy. This is not confirmed in the FINE CKD studies, but it's little plausible from according to the data that have been accumulated in recent years, favoring the use of intravenous iron in patients with heart disease and heart failure. And infection, also you can see 4.3 events for 100 patients a year in comparison to 25.8 and 36 for the REVOKE trial. And finally, I just want to present what was the state of art of the use of intravenous iron in dialysis patients in 2018. A meta-analysis was published, summarizes the same randomized controlled trial which were available at that time. And you can see in particular that There were inserted the data of the dry study, but also a small study for Bozarab, Fadin, Lewis, and Provenzano. Overall, all the studies were quite small, with a total sample size of 400. And you can see from this slide that there was no increased risk with the use of high-dose intravenous iron compared to control from the point of view of mortality. However, this meta-analysis has big limitation because of the small number of participants and events in the randomized controlled trials. And then I'm moving to the conclusion. And as we said, iron is essential for life, and its free concentration is tightly regulated, because if not, it could become toxic for cells. Over the years, the evidence has accumulated on the involvement of excessive iron in influencing pulmonary vascular resistance, endothelial function, atherosclerosis progression, and infection risk. The right balance between hydroiron repletion with adequate therapy and the avoidance of iron overload and its possible negative effects is still a matter of debate for CKD patients. And this is particularly true in patients having functional iron deficiency. And I thank you for the attention, and I pass the presentation to the next speaker. Thank you, everybody.
Thank you, Lucia. That was really nice. Paddy, whilst you share your screen, just a reminder to listeners, please do use the Q&As for questions. We'll try and address as many as we can here, but we will also potentially be able to answer some offline. So Paddy, over to you. Thank you for taking on the challenge of trying to summarize all of the big trials in 15 minutes.
Okay, I'll do my best, as long as you can hear me and you can see my slides, which I think we're all okay. And thanks for that masterful overview of the basic science and the non-dialysis trials. So I'm really going to talk pretty much about iron and the heart, but hopefully with relevance more to the nephrologist, but coming first from the cardiovascular background. So I work in Glasgow, and I've moved rooms, so I now at least the light on. So I think the initial interest in trials to me comes actually not from an iron trial, but comes from RED-HF, which was a trial of an erythropoiesis stimulating agent in patients with heart failure and diabetes, just with heart failure. So I'm getting confused between treat and RED-HF, which is a heart failure trial with darbepoetin. And you know, this came from all this stuff in the early 2000s, that anemia was bad for patients with heart failure, and therefore treating anemia was needed. And the initial big trial, RED-HF, showed that actually there was no benefit of treating anemia primarily using erythropoiesis stimulating agents, which to me says, well, clearly it's the iron that's required rather than the ESA to drive the hemoglobin per se. So this trial was negative, as they say, and didn't show any particular benefit of treating anemia in people with heart failure with an erythropoiesis stimulating agent. So what about iron? So first of all, looking at iron in the heart, and I don't want to dwell too much on basic science because I've got to get to the big clinical trials, but looking at some of the basic science, looking at the myocardial iron content in explanted hearts of people awaiting obviously undergoing heart transplantation, they do appear that iron is depleted in the people with failing hearts, and this seems to affect enzymatic activity, of generating ATP, etc., and for people with heart failure. And just to say that this study has been done, it's a basic science study. And what I think is interesting is in the panel in the top right is that even in people with with heart failure without anemia, I did appear to be iron deficient compared to controls. But I'll not dwell on these studies because I really think there's some exciting data from trials to look at, both from cardiology and from nephrology. So first of all, the trials in the heart failure world, there have been a number of mechanistic or surrogate outcome clinical trials of intravenous iron therapy in patients with heart failure. These surrogate outcome trials have tended to use subjective mid-endpoint sort of things like 6-minute walk tests for functional capacity or quality of life or patient global assessment. They've also looked at trials at oral iron, but the iron out trial of looking at oral iron really was negative and showed no benefit of oral iron. So let's move on to the trials looking at surrogate endpoints. And this is a meta-analysis, an individual patient data meta-analysis of trials using ferric carboxymaltose, or Ferinject as I would call it, in heart failure patients. And the ones that I'm are familiar with that really sort of twigged my attention were FAIR-HF and CONFIRM-HF, which were trials of ferric carboxymaltose in patients with heart failure. Looking in one CONFIRM-HF looked at 6-minute walk test, and the other one looked at the sort of the global assessment of the patient, a kind of well-being score. So the interest of these trials done, and I think we say that they all seemed promising, seemed in the general direction of positive for the endpoints that they looked at. But in a meta-analysis of harder endpoints from these trials, we can see that when we look at a combination of cardiovascular hospitalizations or mortality, we see a really reasonably strong signal of benefit with intravenous iron compared to no intravenous iron. And as I said, I think the trials which kind of drive that are FAIR-HF and CONFIRM-HF, which are the larger trials, which seem more conclusive also in their surrogate endpoints as well. So these trials showing surrogate benefit and meta-analysis benefit on harder outcomes have led to bigger trials, first of all, in acute heart failure, and there are ongoing trials in chronic heart failure. So AFFIRM acute heart failure appeared just last month, and in our review, we referred to that this trial was ongoing. It has since been published. So I thought I'd just update on that. And this trial was in patients who were hospitalized with heart failure and had iron deficiency and systolic dysfunction. And prior to hospital discharge, they were randomized to receive intravenous ferric carboxymaltose or placebo, with subsequent doses offered if the patients in the active treatment arm were still iron deficient down the line, and with a primary endpoint of hospitalizations for heart failure, cardiovascular death. And what I love about this study, and all the iron studies, is of course they had to use a placebo with a black syringe. I think that's great. You either cover up the bag or you use a black syringe to make sure it's a proper placebo-controlled trial. So what did they show? Well, this trial was positive for its primary outcome. In the top left of the slide, there was a significant reduction in the primary outcome of heart failure hospitalizations and cardiovascular death with ferric carboxymaltose compared to placebo. And it really looks across the board in this that there was benefit on many of the signals, but no change in cardiovascular death, but all of the things based around hospitalizations or heart failure seem to be a positive signal. So in patients with heart failure, ferric carboxymaltose compared to placebo was associated with better heart failure outcomes. So I think that's moving this field forward. So I've shown you so far very briefly that patients with severe heart failure have reduced myocardial iron. I've shown you the notion that intravenous iron improves quality of life, so life and outcomes. And we now have an outcome trial which shows a benefit in acute heart failure patients. There are ongoing trials in chronic heart failure patients, outpatient heart failure patients who have not decompensated, where they're being administered intravenous iron. There's Ironman and FAIR-HF. I believe Ironman is still either in recruitment or is close to recruitment, but it's in the UK and it's at fairly advanced stages. And it'll be interesting to watch this space over the next couple of years to see if what role intravenous iron has in these patients. But I'm a nephrologist, and we've done some. I love this next bit because we've actually done an intravenous iron outcome trial before the cardiologists. So in the United Kingdom, and I'm delighted that Dr. Winearls is joining us because he was in a steering group for this trial of pivotal or proactive intravenous iron therapy in hemodialysis. And the hypothesis of pivotal was that high-dose intravenous iron would be non-inferior to reactive iron in the outcome for all-cause mortality and cardiovascular events in hemodialysis patients. And what do we mean by proactive iron? Well, we mean that these patients were dosed with intravenous iron at 400 milligrams per month, unless there was evidence that they were really iron replete. Their TSATs were over 40%, or their serum ferritin was over the edge, which we felt was too high. The reactive arm were only given iron if they were actively deficient, if their TSATs were less than 20% or the ferritin less than 200. These were patients who were new to dialysis. They were in the first 12 months after commencement of dialysis, they were recruited. They did require to be treated with an erythropoiesis stimulating agent, and they did require to have a TSAT less than 30% at the time of randomization. Randomized 1-to-1 and followed up for the primary endpoint of sorry, I can't quite see it the way my slides are lined up, but followed up for a cardiovascular endpoint. So the endpoints were composite of MI, stroke, hospitalization for heart failure, or all-cause death. And then there was a variety of secondary endpoints. I'll not dwell on these in the interest of time. So they looked like a pretty standard UK dialysis cohort, median age 65, fair proportion of diabetes, fair proportion of hypertension, and some had prior cardiovascular disease. They were mildly anemic, and the ferritin was unremarkable. So pretty representative. I like to put this slide in because I'm presenting this from my kids' playroom actually now. This is San Diego, and I don't know if our chair, Dr. Herrington, remembers, but he and I were sitting beside each other in the auditorium in San Diego at an ASN when these results were presented. And I just hope we get back to going to normal conferences within sometime soon, because it would be lovely to see everyone again. So sort of fond memories. Right, what were the results? So this was great because it was a big trial done in nephrology in the UK. And if it didn't quite have a positive result, it certainly was an informative result. The trial certainly showed conclusively that higher dose iron or proactive iron was non-inferior to reactive iron. And for superiority, it was just significant that there was a relative risk reduction in death, MI, stroke, or hospitalization in these patients. Furthermore, in data which I was lucky enough to present at the ERA earlier this year, we showed really that's quite a strong signal that the proactive iron reduced the risk of myocardial infarction in patients with on dialysis in the pivotal trial. And I think that's interesting. We look at the atherosclerosis stuff that was presented earlier. We look at death from any cause, and this was not statistically significant, but I think we worry with iron about driving risk of infection and things like that. And if anything, the risk of death was lower, but did not meet or was very nominally on the borderline for statistical significance. And I'm sure Chris might want to comment further on this. So overall, proactive iron reduced the risk of MI, stroke, or hospitalization. Certainly on MI, it really had a more striking signal with a hazard ratio of 0.69, so 30% relative risk reduction. Stroke, no signal at all, unlike some of the anemia trials with erythropoiesis stimulating agent, no signal of harm for stroke. And again, for heart failure, quite a strong signal of benefit with a 34% relative risk reduction with proactive iron. What about safety? I think it's interesting, these patients required less transfusions and less ESA, but we do see, although it's not statistically significant, we do see more vascular access thrombosis in the proactive arm, i.e. the reactive arm has less vascular access thrombosis, so that is interesting. But no signal of problems with infection that I can detect. And actually in a follow-on paper, which I was involved in, there seems to be really very limited, there seems to be right down the middle for the line of effect that neither proactive or reactive groups seem to have any particular excess risk of infection. So just to round up quickly on time, I think in the heart failure patients, we're seeing increasing benefits with intravenous iron in patients with mild anemia and or iron deficiency. In pivotal, in dialysis patients, in a large randomized controlled trial, in a group of patients who are representative of general dialysis patients, high dose intravenous iron had less heart failure, less myocardial infarction, lower ESA use, and less transfusions. I think we do need a bit more data on younger patients who've been on dialysis for longer with proactive iron. I think that is a gap in pivotal if I'm going to critique a UK trial. I think I would love, as Lucia highlighted, the non-dialysis CKD group really don't have outcome data like they're trying to generate in the cardiology world. And I think that would be an interesting group to study. And clearly, as we highlight in our paper, there's lots more work to be done. Although Pivotal's a really striking trial, there's lots more work to be done on the mechanisms, the generalizability, the health economics and all of other aspects of this. And with that, I will hopefully hand over to our chairs and put up. So our paper appeared today online in CKJ, and we're pretty proud of it, and it looks great. And I'd like to thank all the CKJ team for turning this around so promptly.
Thank you, Paddy. Thank you, Lucia. That's great. May I start with a question before I release Chris Winearls on you? Length of follow-up, I think Pivotal obviously shows safety in terms of infections and at least short-term on the heart.
Yeah.
I think the only uncertainty left for me really is long-term safety, particularly on heart and other tissues. Any chances of long-term follow-up? Is there anything more going to come from Pivotal trial patients?
I don't actually know is the honest answer. So the data set are currently still in my institute. I think the problem is that follow-up, there was a lot of money put into making sure we had really good follow-up during the duration of the trial. And I'm pretty sure they're all consented to be linked through UK Renal Registry and or other mechanisms, but it's going to be really difficult to have high quality data, particularly around heart failure, which was the big thing in the endpoint, which is impossible to adjudicate in dialysis patients based on hospital records, in my opinion. So I don't know. It would be really nice to do that because again, we'd have better data on infection, on different, as mortality longer term. But I suspect we probably won't get more data, but I hope we do.
Okay. I don't know, Chris, are you there with your video? Do you know if there's anything more coming from Pivotal?
I do not, and I think it's an extremely good question, because a bit like the DCCT study, we might want to see whether there's a legacy effect of being in the high or the low dose. But the problem is that this is going to become policy in the United Kingdom. So in fact, we'll never know. People will be given the proactive protocol from now on, and we'll never know whether the proactive protocol in the long term is going to cause a problem.
Okay, so Chris, you've sort of seen EPO introduced, then the introduction of IV iron. I have to admit that I was quite excited when I saw the AFFIRM trial results. When I saw Pivotal, I thought there may be something in it, but now I've seen the results of AFFIRM, I really think there probably is something in the cardioprotective effects of intravenous iron, at least in certain populations. Do you think we're now seeing a transition from IV iron being seen as something which is EPO sparing to being potentially something which starts to be part of people's cardioprotective armamentarium in dialysis patients?
That's a very big question. Cardioprotective. I think Paddy will agree with me that acute myocardial infarction is not the major problem in patients with on hemodialysis. And he might want to tell us the different kinds of MIs that the patients had in the pivotal trial, because that may be informative. So that particular benefit to me is a relatively small one. The other benefit that's much spoken about is the reduction in ESA doses. There may be an explanation for that, which is that in the reactive group, there was a tendency for the iron parameters to diminish. Are you still there? I'm still here.
Yeah, sorry. I thought
here. Paddy's we just got a bigger picture of your face.
Yeah, I thought we should go to the panel discussion now. I thought it'd be nice to see everyone.
You have my sympathy, but I have no control. The issue was really whether that lower ESA dose may have been because there were more patients in the reactive group who were on the borderline of iron adequacy. So I'm not absolutely certain about that. I don't want to appear to be dissing the pivotal study, but I think there's certain things that it did show us, and there's certain things that it did not show us. And one of them is long-term safety. If I could just turn to the infection issue. You know, there's a statement that iron overload may facilitate infections. Let's examine that. Extreme iron overload can reduce polymorph function, but there are a limited number of organisms that are really dependent upon iron, and they are things like Yersinia, tuberculosis, and gram-negatives, not the gram-positives, which are the bane of nephrologists' lives. So I'm not entirely surprised that there was no signal on infection. If I may, could I just change now? We'll come back to Paddy, to Professor Vecchio. You spoke very rapidly about the effect of the HIF system on hepcidin. Did you say it was an indirect effect?
Yeah. At the moment, as far as I know, there is no demonstration that there is a direct effect. The main effect is on increased erythropoiesis, and then erythroferron synthesis, and then decrease in epsilon levels.
Right, thank you. I think that's an extremely important point, and I'll tell you for why. It is being proposed that HIF-prolyl hydroxylase inhibitors will be really good for improving iron balance because they suppress hepcidin. There was a paper which said they directly suppressed hepcidin, but that's never been confirmed. In fact, erythropoietin suppresses hepcidin. That's been studied at the Hammersmith. So just any ESA will reduce hepcidin. The problem is in those patients that have increased hepcidins for other reasons, like inflammation. EPO probably will not reduce hepcidin, and HIF-prolyl hydroxylase inhibitors will not either. So I don't think we should be looking to the HIF-prolyl hydroxylase inhibitors to solve the problem of how we manage the iron balance in hemodialysis patients. I just wanted to quibble with you over something, your definition of functional iron deficiency. I think it's incomplete, your definition, because in fact, what we're really talking about is that the erythropoiesis is iron deficient. So let me give you a crude example. Patients with hemochromatosis who are bled will have iron deficient erythropoiesis, although they have ferritins of 5,000. They just can't get the iron into the erythron quick enough. And so you can get this fall in transferrin in patients also with high ferritins if you're stimulating their erythropoiesis with massive doses of EPO, which we don't, none of us recommend. I'm deeply suspicious of the DOP study and its association with adverse events in relation to ferritin. It is an association study, and the temptation to start looking for a causative effect is very strong and has to be resisted. I've got it in front of me. Actually, the non-cardiovascular deaths and the non-infection deaths were also increased in the high ferritin group. So I think we have to be really, really careful about that. So my overall feeling about this subject is that in the overview of iron balance in dialysis patients, what no one will deny is that these patients are programmed to be in negative iron balance if they stay on hemodialysis. That's unequivocal. So the question is, how do we maintain them iron replete safely? Now we can either do it in several ways. We can either fill up the tank with a massive dose of intravenous iron every time that they're running on empty. That seems to me a stupid way of doing it and raises the possibility of free labile iron being given to them because you kind of overwhelm their processing of the iron. The other is to keep pulsing them. There's also that risk there. So why not give them small doses of iron regularly and keep their iron balance, keep them in iron balance? And the question then will rise as to whether always having a full tank is better than having a half but sufficient tank. And so I think the next question for us in this subject is in fact not so much whether we give intravenous iron, but how we give intravenous iron. Okay, I will just to give Paddy the chance just to tell us a bit about the myocardial infarct story. And
Sure.
also the question about the myocardial infarct story is that there appears to be a relationship with infection episodes and subsequent cardiovascular events. In other words, the acute phase response may be one of the triggers that causes myocardial infarction. So over to you, Paddy.
Yeah, so first of all, I'm aware, but the myocardial infarction, I quickly took the opportunity to find my ERA presentation on this. So I think about 8.5% of patients during pivotal had an MI. Interestingly, which I didn't think would be the case, was that 2/3 of those MIs were type 1 atherosclerotic type MIs rather than the supply-demand mismatch. So I had always assumed that dialysis patients would have more type 2 MI, but in this clinical trial with an adjudication endpoint and committee and all the rest of it, there was more type 1s. And actually, the proactive iron group had less of the type 1 myocardial infarction. The signal wasn't really so strongly there for type 2 MI. Now, clearly, we're looking at smaller numbers and you start worrying about statistical significance. But I think that's intriguing, because that then, do we really believe that iron, is a treatment for MI like a statin? Because I would be much more, my feeling is it's a treatment of myocardial iron, or as Will highlights, the AFFIRM data that it's going to improve heart function. And atherosclerosis wasn't really where I was expecting to see it, but those are the data that we see in pivotal. I think that's interesting. What was the second question? Oh, yes. The second thing was about the infection and cardiac events. And that is interesting. If you look down in the detail of the paper that you and I were both involved in, we do see that in the 30 days after an infective episode, there's this massive jump in cardiovascular events. I think, sort of 2 or 3-fold lift up in the cardiovascular events immediately in the period following an infective episode. Again, whether that's related to iron or anything is difficult to say, but I think it does, go back to the frailty and the perfusion issues which dialysis patients have. There's lots going on there to disentangle.
So we've got time for, I think we've got time for one question from the audience. There's actually quite a lot of very specific questions this week. Some of them are very clinical related, but I think we've half addressed already. I just want, maybe we could definitively say yes or no to it. I think the answer's become clear now with the recent data. Is the mortality and risk of heart failure reduced associated with IV iron as a result of lower EPO doses? So I think we've definitively shown, I think with the AFFIRM data, that it's not just EPO avoidance, it's something more. IV iron has a particular cardioprotective effect on heart failure in particular.
Yeah, I think if I jump in, I think AFFIRM kind of closes that bit of the loop. We didn't know that from pivotal because we had much lower EPO dosing in the proactive group, but the AFFIRM acute HF closes that to some extent, and I think there must be something in the iron itself rather than just EPO. So it's a great question.
And maybe one last question for you, Lucia. Are the animal models wrong? Could actually IV iron be reducing atherosclerosis, and for some reason there'd be something different in the mice? Or do you think we've studied people where atherosclerosis is definitely not the primary driver of cardiovascular disease? We've just studied structural heart disease populations and we're missing some potential harms in certain populations.
I think the topic is quite complex because the first thing, it depends how much iron you give to animals. Probably in animals, you give much more iron than the iron you give to humans. And also, it depends which kind of, let's say, atherosclerosis, vascular disease you are dealing with, because, for instance, atherosclerosis in the general population is different from that we observe in dialysis patients. And last, I think, one important difference between different studies could be the degree of inflammation that you can find. For instance, there are studies linking hepcidin and thus inflammation with atherosclerosis. This could be an important point to better understand discrepancies.
Yeah, that's great. Okay, well, I think we have to draw time. I'm respectful we're eating into people's evenings beyond the time we promised. Really thank you to all, Lucia, Paddy, and Chris Winearls for your fantastic data presentations and discussion. It always extends beyond just reading the paper when we get people who've thought about this for many years describing their assessments and interpretations of some of the nuances, as well as the clear results that we're getting from the really large trials. So I'm becoming convinced of the cardioprotective roles of IV iron. I was a semi-skeptic, I'll call it, after pivotal, but Affirm, I think, is building the evidence base. Please do go to the CKJ website to read the Eureka M review, which is open access and available from today. In December, we're going to take a break from these e-seminars because it's New Year's Eve for us all. Well, it's Hogmanay for Paddy, it's New Year's Eve for everyone else. And then instead we'll be back at the end of January when we'll be welcoming Professor Matthew Weir, and we will also be doing a seminar on an SGLT2 inhibitor paper. These are really important class of drugs which will be coming into clinical practice more and more. He has written a paper in CKJ about potassium in particular, with some data from the Canvas trial. So we'll be back in the last Thursday of January for that. So thanks again for joining, and sorry we couldn't answer all of your questions tonight.
Thank you, everybody.
Thank you, everybody.
Thank you.
Thank you.